Thank you, Shreyas, for inviting me to your wonderful IC. Been part of it many times. Nice to learn. Keratoconus and inflammation, how should I deal with it as a clinician? These are my financial interests. If there's one thing which COVID has taught us, it has taught us two things. I said one, but two. One, the power of immunology. The second is the power of rapid diagnosis. And that's been the power of how we've been able to break the barriers of COVID's relentless problems it created in the early 2020. Something similar, we worked on it. I don't want to go into this busy slide. This was part of my PhD 7 years back, which looked at all the factors which may cause changes in the corneal collagen. From the time you rub your eyes or don't rub your eyes, each cytokines and what it does do, a forward feedback and also it has a loop mechanism. This was one of the first paper we published this in IOBS. This is the first paper like what Shreyas said, which kind of started linking driven inflammation to keratoconus. It took a long time for us to put this paper, 4 reviews for different people. And finally, it was reviewed by the editor then, and he sent us the final comments about many things. And then we started publishing a lot of papers on inflammation and how it's driving it. One of the things about this particular paper is we used in a small subset cyclosporin as a control arm. And we found that over the 6 months time, people who were rubbing their eyes stopped rubbing, and there was a lot of changes in the keratoconus picture itself. Then came a lot of other papers about the lysyl oxidase, which holds the collagen and how it changes, and how the lysyl oxidase has an optimal link to an optimal outcome. This is a small picture animated about how each cornea has collagen and lysyl oxidase in this kind of a picture. And if you have more of them, your cross-linking is optimal. If you have less, then you have flattening. And you have none, then you actually have very little cross-linking because it's a endogenous cross-linkers. So more is better. Too much is also not good. Too little also is not good. Too much you end up in excessive flattening. That's why you have flattening over years. That is one of the things which we need to be aware of. When you do a cross-linking on a normally having collagen, cross-linking is completely different. Even though the topography sometimes some people operate on a Fromfrust and other things, but it is very challenging if you operate on a normal one. How is it driven? This is a very important experiment which we did, where we recreated the environment of the collagen and the lysyl oxidase, created the same environment of inflammation, what we just published. And what we found was very interesting. When you have a high MMP9 activity, your lysyl oxidase and collagen falls down. That means MMP9 and a lot of his friends of MMP9 drives this. So our paper of 2014, which talks about using cyclosporin in a small subset, works well because cyclosporin works on this complex here. And that's why when you drive down the inflammation, you increase the lysyl oxidase, and that is clearly being shown. That is the most important thing. Then we started looking at cells. This is the corneal epithelial cells, in vitro model. These are your mitochondria, Golgi bodies, all that we studied in our physiology in our first year, it's all here. Under inflammation, these cells start behaving completely differently. And how do we apply this is when you have allergy, when you rub your eyes, all the cells have a different functions. So one of the most important thing for a clinician is look for an IgE. If it's high, treat it. I'm not going to go deep into this because it's all freely available in IGO. And eye rubbing driven by IgE has to be targeted by looking for allergy and reducing the allergy potential, or even doing sometimes very bad cases, we even do a sublingual immunotherapy for that particular allergen. So immunologist is a very important part of keratoconus flow in your clinics. The inflammatory markers, I did mention about this paper, cyclosporin, and this was, and we still use it. I use it for 6 months. suddenly drops down the MMP. I told you, when you MMP9 drops up, your collagen and lysyl oxidase increases. And patients who have a lot of allergy and eye rubbers, post cross-linking, I use it. It also reduces a lot of scarring because the wound healing pathways completely change. Then we started looking at a very interesting concept of autophagy, because autophagy was then a very important topic 4 years back, because that year the Nobel Prize went to a guy who discovered autophagy. We started looking at autophagy in different diseases like cornea, dry eye, and all those places. But one of the reasons autophagy is that it really helps the cells to function or clean the dead. It's a housekeeping mechanism. So we found that completely absent in keratoconus. It is something very low. So that's the whole concept of the drug, which is disaccharide sugar, trehalose, which is used in various other parts of the body for, it's not just specific to the eye, for a lot of autophagy-driven cancers. So we started using it, and you can see that once you start using the same thing, the same cells which were non-functioning here starts suddenly becoming better. And you can see all these cells which were here. Look at this side. The cells were completely dead and the organelles are not functioning, and suddenly they become better. This just shows the power of these cells. Then started using it on patients. This is the drug of choice for me. And we can see that this is non-cross-linked patients, and we have lots of them. I mean, we're just compiling it. You can see that you start flattening. That's because just not rubbing eyes. These are non-eye rubbers. All patients of keratoconus don't rub the eyes. You can something called white inflammation. You can have inflammation in your eyes without rubbing. So you can see that without anything, the lysyl oxidase starts pumping up. And these are all cellular mechanisms as clinicians we should be aware of, because we need to know why they work and where they work. And every molecule has a kind of link for which you can target it specifically. Vitamin D has been very important. Why is vitamin D important? We started looking at epithelium, and we started looking at how each epithelium responds to the vitamin D receptors. You can see that at the cone area of the cornea, the vitamin D receptors was very poor. So why it's important is because even COVID, we have known that the person who goes to ICU care is the one who has the lowest vitamin D, and that's been published in NEJM. It's an immunomodulator. If you have an absence of that on the cone, then you have a chance of more inflammation there and a more effect. So that is why it changes the extracellular matrix completely. So to sum up, I'll just take a 1 more minute, Shreyas. And to sum up, look at the signs of inflammation, treat the signs of inflammation. The worst one can be cyclosporin, but a better one can be with trehalose. Vitamin D is a very important vitamin as far as immunomodulator in keratoconus is concerned.
Sorry to interrupt you, sir. Can I ask the others to put their audio on mute, please? Madam, Dr. Lavingia, madam, I think you have switched on your...
Yes, correct.
Could you kindly put it on mute? Please continue, sir. Sorry for the interruption.
No problem. So IgE, I did mention a simple algorithm, less than 300. Take care of the anti-inflammatory. Don't rush into cross-linking immediately. More than 300, immunologist's opinion really helps in planning. And these are the papers, and we even developed a risk scoring. Based on every level of risk scoring, right? The highest risk are the people with lots of eye rubbing and allergy. For them, the cyclosporin. Otherwise, we feel that trehalose-related compounds just very work well. And if you have a lot of MMP9, like lid conditions, doxycycline works very well in these patients. So this is what I can see at this point of time. It's a link to the clinics. And how do you move forward? I just want to go quickly. This kit is now in the clinic. It used to be something it used to be on a, I would say, from a scientist point of view. Now we have this panel. We do it in our clinic regularly. It picks up all these markers, and it helps us to now decide when I need to use what drug. I need to use, if it's very high over IL-6, I use cyclosporin. If it's IL-8, MMP9, IL-6, trehalose works well. So it's a complete game changer in practice. Thank you.